I'd like to welcome everyone to this lesson of hypertension. And for this lesson, we will be discussing the basics of hypertension and its clinical pharmacology. So let's first define hypertension. And the best definition of that would not be actually numbers, but this idea that hypertension is the sustained increase in blood pressure that characterizes a group of patients with increased risk of hypertension-related cardiovascular sequela. Ibig sabihin niyan, yung mga taong may hypertension ay mayroong mataas na blood pressure that places them at increased risk of developing cardiovascular disease as a result of that high blood pressure. So whatever the value of that blood pressure is, as long as it places the patient at risk, and that is the definition of hypertension. And so ang ginawa ng mga doctors and researchers would be to identify ano yung pinaka-common na blood pressure values upon which this level predisposes the patient to this sequela. Okay, so they gathered population data to do that. Okay, so at a glance, hypertension is the most common cardiovascular disease. And not only that, hindi lang siya disease, but it is also a risk factor to developing a lot of other cardiovascular diseases. Hypertension, the prevalence, ibig sabihin yung dami ng meron nito ay dumadami habang tumataas ang edad with advancing age. And hypertension causes pathological change in the vasculature, in the blood vessels, and it causes pathological change in the left ventricle in the form of hypertrophy. So here is a very important table that you should be familiar with. The normal blood pressure, ibig sabihin lang nun, at blood pressures which have values lower than this, then the risk of cardiovascular sequela would be very low. Okay? That value is less than 120 millimeters mercury of systolic blood pressure and less than 80 millimeters mercury of diastolic pressure. Everything above that would be deemed abnormal. So elevated blood pressure has a value of 120 to 129, but still less than 80 millimeters mercury of diastolic blood pressure. Hypertension technically would be a blood pressure of 130 to 139 millimeters mercury systolic or 80 to 89 millimeters mercury systolic for stage 1. And for stage 2, that is above 140 systolic and above 90 diastolic. And hypertensive crisis would be above 180 and or above 120 millimeters mercury. Okay, so we really don't know the cause of hypertension when we are dealing with primary hypertension. So, pwede yung hypertension primary or secondary. Okay? Pag sinabi nating secondary hypertension, there is a disease that causes as a manifestation an increase in blood pressure. Pag sinabi nating primary hypertension, the disease itself is the increase in blood pressure, or it can also be called essential hypertension. Hindi natin alam what causes primary hypertension, but we know that there are four principal mechanisms. No? Ano yung nangyayari sa loob ng katawan that in effect causes the hypertension? Number one would be dysregulation of the autonomic nervous system. So ang nangyayari dito, the balance between sympathetic tone and parasympathetic tone is abnormal, and there is a favoring of the sympathetic nervous system. Okay, so yung sympathetic nervous system ng patient is very much active compared to the parasympathetic nervous system. And there is an excess release of norepinephrine. And if you will just recall, the effects of norepinephrine and epinephrine on their receptors in the heart and in the vasculature, then you will be able to appreciate why an excess sympathetic tone leads to hypertension. So, letter A, the dysregulation of the autonomic nervous system is the predominant mechanism in patients who are hypertensive and at the same time are young. Okay, so whenever a patient comes in, bata pa, no? Let's say 20s, early 20s, or even early 30s, and we are able to determine that they are hypertensive based on three blood pressure readings, and the value is at 130 and above, and they are young, una nating iisipin, the principal mechanism for the hypertension is a dysregulation of the ANS. And therefore, the most effective means would be to give these patients beta blockers. Kasi ang cause ng hypertension is the autonomic nervous system. So we want to block that. Okay? So but most of the time, it is almost always a combination of these mechanisms. Okay, so in that patient who is young and hypertensive, often malalaman natin that they are in a high stress environment. Okay, so next, etong dalawa naman, the expansion of the intravascular volume and the dysregulation of the renin, angiotensin, aldosterone system are the predominant mechanisms in patients who are of middle age and are hypertensive. So you will understand that when the intravascular volume, ibig sabihin nun, yung volume ng dugo, which is in part determined by the volume of plasma, which is determined again by the amount of water and the amount of sodium, you will understand that as this volume increases, the stroke volume increases, and the cardiac output increases, and the blood pressure increases. Okay, so in these patients, the kidneys have a poor function of eliminating the excess volume. And so when this volume builds up intravascularly, this translates to hypertension. In summary, via the Frank-Starling mechanism. Okay, so to combat that, our goal of therapy would be to provide antihypertensive agents that decrease the intravascular volume, and that is through diuretics. Okay, so again, letter B, the expansion of intravascular volume is the predominant mechanism in hypertensives, usually of middle age. No, next would be the dysregulation of RAAS, and as you will recall your previous lesson, the end effect of the renin, angiotensin, aldosterone system would be to produce vasoconstriction, and at the same time reabsorb sodium and thereby water via the action of aldosterone. So in these patients who are who have a dysregulation of RAS, there is a loss of capture of the negative feedback. No? So you should recall that the stimulus for the activation of RAS would be low perfusion of the kidneys. And when RAS is activated, there is vasoconstriction and reabsorption of water, then the perfusion increases and the stimulus disappears. Therefore, RAS at that instance should stop from being activated. But in patients who have hypertension with the mechanism of a dysregulation of RAS, this negative feedback is lost. even if the perfusion is already corrected, no, the loss of perfusion of the kidneys is already corrected, RAAS is still activated. And so these patients inevitably develop hypertension. And lastly, the last principal mechanism would be a decrease in vascular compliance. And we usually see this mechanism as the major player in patients who are elderly and who have hypertension. Because as one ages, the blood vessels, particularly the arterioles, just lose their elasticity. And therefore, these blood vessels would remain hardened and not pliable. So, which means when the force that acts on the blood vessel wall increases, they do not distend, but instead remain in their caliber size, and therefore the pressure that is applied on the blood vessel wall would increase. Okay, so this is seen in patients who are elderly, those who have aged, and those who have vascular disease, okay, or damage. So again, the four principal mechanisms: dysregulation of the ANS, expansion of intravascular volume, dysregulation of RAAS, and decreased vascular compliance. So I hope you can correlate this with the determinants of blood pressure. Okay, so let me just recapitulate that there are two forms of hypertension. Primary hypertension, kung saan hindi natin alam kung ano yung nagkukos ng hypertension, and the hypertension is the disease itself. And secondary hypertension, where a disease has as its manifestation an elevation of blood pressure. So ibig sabihin nun, hypertension is secondary to these disorders. So, pasadahan lang natin, no? First is renovascular hypertension. Ibig sabihin nun, on the blood vessels that supply the kidney, mayroong abnormality. So it's either mayroong nakabara sa renal artery, and so blood flow to the renal parenchyma, or the organ itself, is low. So kung konti yung blood flow niya, para kang mayroong stimulus for the activation of RAAS. And so the end effect would be hypertension, because RAAS is continuously activated dahil mayroong bara yung blood vessel to the kidney. Next is renal parenchymal disease. And this in itself can be a cause of hypertension or an effect of hypertension. So whenever there is renal parenchymal disease, the ability of the kidneys to regulate blood pressure through the filtration of sodium, yung balance na iyon ay nawawala. So, it's an effect of hypertension. Anong ibig sabihin nun? Kung mayroon kang hypertension, the blood vessels that are inside the kidney, okay? So, the blood vessels that are inside the kidney are destroyed, and that leads to a cycle, which I hope you will read about later, where there is hyperfiltration, and the hyperfiltration injures the nephron itself. And when the nephron is injured, then the balance that determines blood pressure is tilted towards an abnormal side. And so this hypertension forms a vicious cycle. Mataas yung blood pressure, nasisira ang kidney. Dahil nasira ang kidney, tataas ulit yung blood pressure. Okay? So, that is renal parenchymal disease. In Cushing's disease, there is an elevated level of cortisol. And remember that cortisol, although it has poor mineralocorticoid activity, ibig sabihin nun, yung function niya is not as effective as aldosterone in causing reabsorption of sodium. But even if that is the case, cortisol is not an avid mineralocorticoid hormone, no? In Cushing's disease, the levels of cortisol are very elevated such that kahit konti lang yung effect ng hormone itself in reabsorbing sodium dahil sobrang dami ng hormone, sobrang dami nung nare-reabsorb niya na sodium, and this manifests as an elevation of blood pressure. Why? Again, because where sodium is, water follows. So when sodium is reabsorbed, instead of being excreted in the urine, the levels of sodium in the blood increases and therefore water increases and plasma expands. Okay? Plasma, when it expands, leads to an increase in venous return, an increase in stroke volume, an increase in cardiac output, and therefore an increase in blood pressure. Conn's disease naman is actually it can be primary hyperaldosteronism or secondary hyperaldosteronism. But the common theme is there is an elevated level of aldosterone, which is the principal mineralocorticoid. So, ang nangyari dito, aldosterone, if you will remember your physiology, will act on the distal convoluted tubule and the proximal collecting duct. Okay, so dalawa yung sites of action niya. And the effect would be to reabsorb sodium and upon its reabsorption, eliminate potassium. So in elevated aldosterone levels, you will see that sodium in the blood is very high, but potassium would be very low. But because sodium is very high, then hypertension will also ensue. So in pheochromocytoma, letter E, there is an excess release of epinephrine. And epinephrine acts on the heart to increase cardiac output and also in the blood vessels to cause vasoconstriction. Pheochromocytoma is a tumor of the adrenal medulla, and that tumor secretes a lot of epinephrine. In thyroid dysfunction, there can be hypertension from either too much thyroid hormone or too little thyroid hormone. So, in one example, hyperthyroidism, you should remember that the effect of thyroid hormone would be to increase the levels of adrenergic receptor. So, when the levels of adrenergic receptor increases, then a lot of epinephrine will be able to exert maximal effect. So that goes back to the effect of the sympathetic nervous system to increase cardiac output and to increase vascular resistance. So in hyperparathyroidism, the end effect that we observe is an increase in calcium levels in the blood. And remember that calcium is a stimulant of cardiac activity at the heart muscle. Why? Because calcium is required for muscular contraction, and that leads to an increase in cardiac output. Calcium will also lead to hypertension by stimulating the smooth muscle of the blood vessels to contract. And when this happens, there will be vasoconstriction and therefore hypertension. Next would be fibromuscular dysplasia. So fibromuscular dysplasia is a type of tumor of the blood vessels. So when this happens, then the caliber of the blood vessel decreases. And when this happens in the kidney, okay, the renal artery, then you have some form of renal vascular hypertension. But just imagine that when this disorder happens in the blood vessels, the reactivity of the blood vessel decreases. So ang nangyayari dyan, The blood vessel loses its ability to perform myogenic autoregulation. So kapag siya ay na-stretch, hindi siya mag-shrink, at kapag siya naman ay too shrunken, hindi siya mag-stretch. Okay, so that in effect leads to hypertension. So those are the causes of the most common causes of secondary hypertension. Renovascular hypertension, blood vessels supplying the kidney is damaged. Renal parenchymal disease, the kidney itself is damaged. Cushing's disease, there is an elevated level of cortisol leading to excess sodium in the blood. Conn's disease, there is an elevated level of the principal mineralocorticoid, which is aldosterone. Pheochromocytoma, which is a tumor of the adrenal medulla, which is hypersecreting epinephrine, which leads to increase in cardiac output and blood vessel constriction. Thyroid dysfunction. Our example here is hyperparathyroidism, which in effect leads to excess sympathetic activity because thyroid receptor has a permissive effect on the adrenergic receptor. Hyperparathyroidism, which has an end effect of increase in calcium, and that activates the heart muscle, and that causes the blood vessel to contract, and therefore the blood vessel caliber lumen to decrease, and therefore increase in blood pressure. And fibromuscular dysplasia, where the natural activity of the blood vessel is lost because there is a tumor in the blood vessel itself. Okay, so all this time we have been talking about hypertension, what the disease is, what other diseases can cause hypertension, what the mechanisms of hypertension are. And all of that is because we want to prevent the diseases that increase in their chance of developing when there is hypertension. So we want to prevent these sequela or adverse effects of hypertension. So these are the pathologic consequences of hypertension. There are four principal organs that can be affected: the heart, the brain, the kidney, and the blood vessels themselves, which are the cause of hypertension but can also be the target organ of hypertension. So let's first discuss the pathologic consequences in the heart. What happens to the heart when there is hypertension? Okay, so let's just enumerate and cite one example. Left ventricular hypertrophy. The left ventricle increases in size. Congestive heart failure. The ability of the heart as a pump to cause forward flow of blood fails, and therefore blood dams up and backflows retrogradely in its circuit. So, for example, when the left ventricle fails, then blood is not pushed forward, and therefore blood dams up in the left ventricle and in the left atrium, and backward, so on and so forth. The lungs, the right ventricle, the right atrium, and the systemic circulation. Atherosclerotic coronary artery disease. When there is elevated blood pressure, the blood pressure on the coronary arteries, which are the blood vessels that supply the heart, causes these blood vessels to become damaged. And whenever these blood vessels, the coronary arteries, become damaged, they undergo a change which predisposes them to having inflammation and having a build-up of cholesterol plaques. And whenever these cholesterol plaques would break off, they would flow forward and block the smaller branches of the coronary arteries. And therefore, those branches which become blocked do not supply blood to the myocardium, and the myocardium dies. So in essence, that is a heart attack. Okay? And lastly, cardiac arrhythmias. So whenever the heart enlarges so much or a portion of the heart dies off because of a heart attack, then those portions of the heart, the one that enlarged and the one that died off, will not be able to conduct current, and therefore those regions will become prone to developing arrhythmia. Okay, so I'd like to highlight left ventricular hypertrophy. So alalahanin nyo that whenever the blood pressure is high and the cause of that elevated blood pressure is an increase in total peripheral resistance, yung kailangang kalabanin ng left ventricle in its generation of pressure will be very high. And so the left ventricle will adapt by increasing its size and the bulk of muscle which is present in the left ventricle. So this increase in size is termed hypertrophy. So dahil malaki na yung muscle mass na iyon, mas malaki din yung kakailanganin niya na oxygen, and therefore that portion of heart muscle is prone to developing a heart attack kasi mas malaki yung kailangan niya ng oxygen, but the blood flow that is supplied to it does not adapt as well. Okay? Okay, let's go to the adverse effects of hypertension on the brain. So first is stroke. So yung process na nangyari sa puso, kung saan yung blood vessels ng puso nagkakaroon ng plaques, yun nangyayari din sa blood vessels ng utak. And whenever those break off, a stroke develops. Okay? There can be impaired cognition. So nakita nila na yung mga hypertensive patients at their middle age, whenever you follow them up, they will have accelerated development of dementia than those patients who do not have hypertension. And the reason for those would be either a loss of brain tissue from a stroke of a big vessel, or mayroong mga satellite strokes that happen in the smaller vessels. Okay, so whatever the case is, you lose brain tissue, and therefore the ability of that brain tissue is also lost. And lastly, whenever there is hypertensive crisis, a blood pressure that is above 180 millimeters mercury, if you do not control that, then that elevated blood pressure will damage the blood vessels that supply the brain. Okay, so the autoregulation is lost, and there is hyperperfusion of those blood vessels, and that leads to what we call as hypertensive encephalopathy. Okay, so it's an entire brain that is affected because of hyperperfusion. Sobrang bilis ng blood flow. Okay. Next, in the kidneys, you should understand na yung kidney as an organ itself is basically a collection of lots of capillaries, lots of blood vessels that communicate with epithelium, no? And this epithelium processes the urine. So isipin nyo, para siyang malaking bola ng blood vessels. And therefore, kung meron kang hypertension, dahil isa siyang collection of blood vessels, doon nyo din mabilis makikita yung adverse effects of hypertension. And the first to be injured is usually the glomerulus. And remember that the glomerulus is a tuft of capillaries. And whenever there is excess blood pressure and there is shearing of the endothelium, the glomerulus is injured. And when the glomerulus is injured already, then hindi niya na ma-filter out ng tama yung mga proteins and materials that are in the blood. And they find their way into the tubules of the kidney. And so later on, the glomerular injury can progress to tubular injury. So yung tubules ng nephrons mismo yung nasisira. And later on, when this is uncontrolled, remember yung sinabi kong process kanina, kung saan um, the blood pressure increase damages the endothelium, and the tubules later on become damaged, which will perpetuate a vicious cycle of increasing blood pressure. So, kapag paulit-ulit yung cycle na yun, continuously you will experience a dropout in nephrons. And later on, when almost all of the nephrons have been destroyed already, um, you have now end-stage renal disease. And this time, this is your hypertensive nephropathy. Okay. Lastly, sabi ko kanina, the peripheral arteries can be a cause of hypertension or a target end organ of hypertension. So, kanina dinescribe na natin yung process in atherosclerosis, but just imagine those processes happening in the bigger arteries of the body. For example, those supplying the lower limbs or the legs. So, kapag nababara yun, whenever the patient would walk, and the demand of the leg muscles for oxygen increases during exercise, but the blood vessels are clogged, then those patients will experience pain during walking. And that phenomenon is what we call intermittent claudication or peripheral claudication. So just imagine that whenever those blood vessels will become clogged, of course, hindi niya nasusuplayan ng dugo yung tissues doon, and those tissues can necrose or die. Okay? So, that is, in essence, peripheral arterial disease. Okay, so the pathologic consequences. Remember, four end organs: the heart, the brain, the kidney, and the peripheral arteries. Much of our hypertensive patients will die from cardiac consequences. And the next would be strokes. So the second leading cause of death in hypertensive patients would be a brain attack or a stroke. Okay? So, do you now get the importance why we really have to be aggressive in our treatment of hypertension? Okay? Okay. So now let's proceed to how we actually treat hypertension. So the question that comes to mind first would be, do we proceed with just giving one agent, or do we have to combine agents? It is actually upon the discretion of the physician. If the doctor would like to have an aggressive approach, then he or she can initiate a combination therapy at the outset. But most of the time, it is very prudent to have monotherapy. And if that single agent does not work, we increase the dose. If still we do not see an appreciable decrease in blood pressure, then we can add another class of agents. And the goal here would be to utilize differing mechanisms of action to produce synergy in causing a decrease in blood pressure. So the principle is, if we have synergism, then we can effectively decrease the dose of each agent used because they are working in combination. And when we decrease the dose of each agent used, then we can decrease the incidence of adverse effects or side effects. Okay, so the usual combinations that you will find in the market would be an agent that produces vasodilation, and combine that with a diuretic, or combine that with a beta blocker. Okay, so you will find out later why. Okay, first drug classes would be the inhibitors of RAS. RAS again stands for renin, angiotensin, aldosterone system. So let's just revisit the pathway. That whenever there is low perfusion of the kidneys would respond by releasing into the circulation renin. And renin, when it is already in the blood, is an enzyme that cleaves off angiotensinogen. So the long peptide angiotensinogen is cut off by renin, and that produces angiotensin 1. Angiotensin 1 then is in the circulation, and when it reaches the pulmonary vascular endothelium, where angiotensin converting enzyme is expressed, it is further cleaved off into angiotensin 2. And angiotensin 2 would be the primary effector as it acts on the receptor, the angiotensin receptor. So at the angiotensin receptor in the blood vessel, that causes vasculogenesis, which is the development of more blood vessels. It causes vasoconstriction. In the brain, it causes a sensation of thirst. And in the adrenal cortex, it stimulates the secretion of aldosterone, which at the end of the day also causes remodeling of the blood vessels in the heart and reabsorption of water and sodium, thereby increasing plasma volume and therefore reversing the hypoperfusion of the kidney. Okay, so that's the renin-angiotensin-aldosterone system. So in this patient, which has hypertension, what would be our goal in providing these classes of medication? We can inhibit the entire pathway in at its initiation, which is at the level of renin. So we have renin inhibitors. The prototype is aliskiren. So, but aliskiren is not used as initial drug therapy, but as adjunct. Ibig sabihin, pinapartner siya with the other agents that act on RAAS. Okay, so kapag hindi gumagana yung mga initial agents na yun, last step would be to provide renin. So when renin is inhibited, angiotensinogen, which is secreted by the liver, is not converted to angiotensin 1. Next, angiotensin converting enzyme inhibitors. We already have angiotensin 1 in the circulation, and now it's time to convert it to angiotensin 2 via the action of angiotensin converting enzyme. So when you block that, the levels of angiotensin 1 increase, and you will know with further reading that angiotensin 1 also has minimal vasodilatory effects. Okay? So when you block that, the levels of angiotensin 1 increase, you will have minimal vasodilation, but more importantly, you block the production of angiotensin 2, which has vasoconstrictive properties and stimulatory effects on aldosterone secretion. So by blocking angiotensin 2, you decrease blood pressure by preventing vasoconstriction and by preventing sodium reabsorption by way of aldosterone. Okay, so a very notorious side effect of angiotensin converting enzyme inhibitors would be the production of cough. Why? Because bradykinin, which is a vasodilatory agent, is broken down into inactive form by ACE. So when you block ACE, then the levels of bradykinin increases. And when the levels of bradykinin increase in the lungs, they will cause distension of lung parenchyma and stimulation of J free nerve endings. So when these J free nerve endings are stimulated, then the cough reflex is activated. So the usual manifestation would be a dry cough in patients who are taking ACE inhibitors. But that is not bad in itself. Angiotensin converting enzyme inhibitors, aside from blocking angiotensin 2 and its vasoconstrictive activity, also increase the levels of bradykinin, which is a potent vasodilatory substance. So it is actually mechanistically very optimal to give ACE inhibitors because they act via two mechanisms, one to block vasoconstriction and the other to stimulate vasodilation. And lastly, we can block angiotensin 2 at its end receptor by blocking the binding of angiotensin 2 on the receptor by giving ARBs, angiotensin receptor blockers. And you know that agents that are angiotensin receptor blockers end in sartan, okay? And ACE inhibitors end in pril. So You know already in your organic medicinal chemistry that ACE inhibitors usually are um, prodrugs which have to be activated by the liver into the active drug metabolite. An exception of that would be enalaprilat, which is given as the active form intravenously. Okay, so the effects of these agents: decreased vascular tone, decreased aldosterone secretion, decreased cardiac remodeling, and kinin-mediated vasodilation. Remember, when you block ACE, you increase the levels of bradykinin, which are vasodilatory. Okay? Adverse effects, of course, an augmentation effect of the inhibitors of RAAS would be hypotension. If you give too much, then you won't have vasoconstriction. Therefore, you can experience hypotension. Hyperkalemia, why does this happen? When you block aldosterone secretion, hyperkalemia, sorry, when you block aldosterone secretion, you won't have the effect of sodium reabsorption. But um, consequent to that would be the blockade of potassium secretion by the nephron. So when you block the secretion of potassium into the urine, potassium in the blood increases, and this leads to hyperkalemia. Okay, so you should be wary of this electrolyte abnormality, especially in patients with chronic kidney disease, because the levels of potassium can be very high that it prevents normal electrical activity in the heart. So the hearts of these patients can stop. Okay, edema. Why is that? When you have vasodilation, you have high perfusion of the blood vessels and therefore high net filtration. Therefore, water in the interstitium can increase. So the next drug classes that we'll be talking about are also agents that cause effects on the blood vessels. These are nitrovasodilators, and phosphodiesterase inhibitors. So the mechanism of nitrovasodilators would be an end effect of increasing cyclic guanosine monophosphate. And you will later see that in the mechanism, CGMP would prevent um, the formation of phosphorylated myosin. Conversely, it increases the rate of dephosphorylation of myosin. So, ibig sabihin nun, yung myosin, tatanggalan niya ng phosphate. So, whenever myosin is removed of its phosphate, its high energy state is lost. Therefore, kapag wala na siya dun sa high energy state, then the myosin won't be able to facilitate contraction of the contractile unit of blood vessels. And at the end of this will lead to relaxation of the smooth muscle of blood vessels and therefore vasodilation. Phosphodiesterase inhibitors, on the other hand, also increase CGMP levels, cyclic guanosine monophosphate, but not on the end of its synthesis, but at the end of its degradation. So ano ibig sabihin nun? Pinapataas niyo yung CGMP hindi dahil pinapabilis na yung paggawa ng CGMP, but piniprevent niya yung pagkasira ng CGMP. So similarly, it will increase the levels of CGMP and increase the rate of dephosphorylation of myosin. Okay, so let's just look at the effects. No, whenever the blood vessel, this time more susceptible ang veins, no, sa effects ng nitrovasodilators. So whenever the veins would increase their caliber, whenever they would relax, their ability to be capacitance vessels increases. The amount of blood that they hold will increase. And when the veins hold more blood, the amount of blood that reaches the heart, the venous return decreases. When the venous return decreases by Frank Starling mechanism, the stroke volume also decreases. When the stroke volume decreases, the cardiac output, which is the amount of blood pumped per minute, decreases, and therefore the blood pressure decreases. So this is the illustration, no, by which nitrovasodilators and phosphodiesterase inhibitors act. So the nitrates that the patients are taking are converted inside the cell into nitric oxide. So these nitrates can be in the form of isosorbide mononitrate, isosorbide dinitrate, amyl nitrite, no, the nitroprusside. So these agents at the end of the day produce nitric oxide. So we are supplementing the nitric oxide by way of drugs. But you should also know that blood vessels have the ability to synthesize their own nitric oxide in response to blood flow requirements or injury. And that is via the inducible nitric oxide synthase pathway. So they converge at nitric oxide, and at the level of nitric oxide, there is a stimulation of the enzyme guanylyl cyclase, which converts guanosine triphosphate (GTP) into its cyclic form cGMP. And cGMP facilitates the dephosphorylation of myosin light chain. So when myosin light chain is dephosphorylated, it leads to relaxation. Okay, so knowing that cyclic guanosine monophosphate dephosphorylates myosin light chain, knowing that um, by preventing the degradation of cGMP, which is facilitated by phosphodiesterase, when we block phosphodiesterase, cGMP increases. And the dephosphorylation of myosin light chain will also increase, okay, leading to relaxation. So there are a lot of phosphodiesterase inhibitors. We have phosphodiesterase 5 inhibitors, and we have phosphodiesterase 3 inhibitors. So PDE3 inhibitors are commonly used for the treatment of heart failure, um, while PDE5 inhibitors, sildenafil, no, which is now commonly linked to erectile dysfunction, no, um, are agents used for the treatment of pulmonary hypertension. So sildenafil hindi lang sa erectile dysfunction ginagamit, but whenever the blood vessels inside the lung are damaged and there is pulmonary hypertension leading to right ventricular strain, no? Yung right ventricle napapagod na dahil sa taas ng resistance na kailangan niyang i-overcome sa loob ng lung. We can use sildenafil to decrease that resistance by this mechanism and therefore help with right-sided heart failure. Okay. Another effect of nitrovasodilators would be an increase in coronary blood flow. Okay, so whenever the myocardium is hypoxic or anoxic in conditions of a heart attack, you can help the patient reperfuse the tissue, no? Increase the blood supply to the myocardium by causing coronary vasodilation. So, isang tinuturo sa board exam would be the acronym MONA for the treatment of acute coronary syndrome. MONA, morphine for pain, oxygen, nitrates, and aspirin. But that is not really a thorough clinical therapeutics of acute coronary syndrome. But it is a very good acronym to remember. MONA. Kasama doon yung nitrates. And lastly, tachycardia. How does that happen? When there is vasodilation, and this is usually seen in nitroprusside, no? The arteriolar vasodilator. So when you provide high levels or high concentration of nitrovasodilators, they will shift their effect from being venodilators to being arteriolar dilators. So when the arterioles dilate, um, the peripheral resistance decreases. And so um, blood pressure in that instance will also decrease. So for the heart to maintain its blood pressure, it will increase cardiac output by increasing heart rate. Okay, so the tachycardia here is a compensatory mechanism. Remember that when the veins dilate, the venous return decreases. And when the venous return decreases, the cardiac output decreases. And so, with a decrease in cardiac output, perfusion of the peripheral tissues will be questionable. So, what the heart does would be to increase heart rate so that cardiac output is maintained, so that the perfusion of the systemic, uh, the peripheral tissues would still be maintained. Okay, so in this case, tachycardia is a compensatory mechanism. And when you use nitroprusside, when you provide it at a very rapid rate, nitroprusside is degraded in the liver into cyanide, and therefore these patients are at risk of cyanide toxicity, which is a cellular poison. Okay, so this is an overview of agents that act on the autonomic nervous system. So commonly, we target the autonomic nervous system at its sympathetic branch when we are trying to ameliorate hypertension. So here you will see the different receptors. The beta 1 receptors providing chronotropy and inotropy. The alpha 1 receptors providing vasoconstriction. The alpha 2 receptors providing an inhibition of adrenergic release. And okay, so those are the three more important adrenergic receptors that we can target to decrease arterial pressure. So this is their relationships, okay? So when you provide beta blockers, you decrease cardiac output and therefore decrease arterial pressure. When you provide alpha 1 blockers, you prevent vasoconstriction and therefore decrease systemic vascular resistance and arterial pressure. When you provide beta 2 agonists, which cause skeletal muscle vasodilation, you decrease vascular resistance and increase arterial pressure. So next, when you agonize alpha 2, you decrease the release of norepinephrine and therefore you decrease both cardiac output and systemic vascular resistance. So first, let's go to alpha blockers. There are non-selective alpha blockers and alpha 1 selective blockers. So the non-selective alpha blockers are phenoxybenzamine and phentolamine. Phenoxybenzamine is the irreversible non-selective alpha blocker, which means when you give that drug, the duration of activity is very long. And so we commonly utilize phenoxybenzamine in the medical treatment of pheochromocytoma, where there is an unprecedented increase in the levels of epinephrine. So dahil hindi naman natin makontrol yung levels ng epinephrine, dahil tumor nga ang nagsasecrete nun, i-block na lang natin yung effects niya by providing phenoxybenzamine, which is an irreversible non-selective alpha blocker. Phentolamine is the reversible non-selective alpha blocker. Okay, so the duration of activity of phentolamine is less than 24 hours. Alpha-1 blockers include prazosin, terazosin, and tamsulosin. So si prazosin and terazosin, they are commonly used for the treatment of hypertension, but what's unique here is tamsulosin, which is utilized for its relaxant effects on the smooth muscle of the prostate, and therefore they prescribe tamsulosin in patients who have benign prostatic hyperplasia, which has a dynamic uh, component. So remember that benign prostatic hyperplasia can both have a static and a dynamic component. So yung static dahil sa laki ng prostate, at yung dynamic dahil sa pag-contract ng prostate. So, kung yung problem ay yung dynamic component of benign prostatic hyperplasia, then you can use tamsulosin. Okay. Effects, arteriolar vasodilation. And special for some alpha-1 blockers would be the relaxation of ureteral and prostatic smooth muscle. So, yan yung naka-illustrate sa photo. Sa taas, yung contracted prostate na sobrang laki. Dahil sobrang laki niya, tapos nakakontract siya, babarahin niya yung pagdaloy ng ihi from the urinary bladder into the penile urethra. Okay, so dahil doon, meron kang urinary retention. Okay? So, aakyat yan papunta sa ureters, papunta sa kidneys, hanggang masira yung kidney dahil mayroong ihi. No? Urine is in itself toxic and must be expelled. So, kapag nag-backflow siya into the kidneys, that will lead to hydronephrosis and kidney failure also. So, we have to relieve that. And one way of doing that would be to give tamsulosin, which will relax the smooth muscle. So, yan yung naka-illustrate dyan. And when the smooth muscle relaxes, yung patency ng urethra increases. So, magpa-flow na yung ihi. Okay? Lastly, reflex tachycardia ulit. Dahil nag-vasodilate, bababa ang blood pressure. So, remember that blood pressure is a force and it propels blood forward. And when blood pressure decreases, the integrity of your perfusion is questionable. So, ang gagawin ng heart would be to increase heart rate, okay, to maintain cardiac output. Okay, so this is manifested by orthostatic hypotension. So, remember yung baroreceptor reflex na diniscuss natin sa cardiovascular physiology. So, the baroreceptor reflex and arc in itself utilizes the sympathetic nervous system. And one portion of the sympathetic nervous system that acts is at the level of the blood vessels by way of alpha-1. So whenever blood pressure is low and the baroreceptors in the carotid and at the arch of the aorta are not stimulated, then the medulla of the brain will understand that as, hey, blood pressure is low. I'm not being pressed. So I need to increase my blood pressure by releasing norepinephrine. This norepinephrine will stimulate the heart to pump stronger and faster, therefore increase cardiac output. But at the same time, this norepinephrine will cause vasoconstriction of my blood vessels and therefore increase my peripheral resistance and blood pressure. So that is the baroreceptor reflex arc. When you paralyze that portion of the sympathetic nervous system at the blood vessels by giving alpha 1 blockers. Therefore, you're preventing vasoconstriction. Um, that portion of the baroreceptor reflex will not function, and therefore, without sufficient vasoconstriction, blood flow to the brain is not corrected rapidly. And this will manifest as dizziness, as there is a portion in time when the brain is not receiving adequate blood flow. Um, Whenever you lie down and then you rapidly sit up, or when you lie down and then you rapidly stand, the momentary um, increase in blood pressure is not rapid. And therefore, when you measure the blood pressure lying down and when you measure the blood pressure standing up, there is a considerable difference. Okay, so that is orthostatic hypotension. Why? Because the sympathetic nervous system at the arm of the blood vessels is paralyzed. Okay, next would be alpha-2 agonists. Examples of alpha-2 agonists are clonidine and methyl dopa. So they are centrally acting, which means they act on the level of the brain stem, and even neurons higher up, no? And their end effect would be to depress the sympathetic tone. So let's orient ourselves with the photo on the right. Okay, so know that there is that presynaptic neuron, and that is on the left, and there is this postsynaptic neuron, which is illustrated here on the right. So the presynaptic neuron will communicate with the postsynaptic neuron by releasing neurotransmitters. So in this case, our neuron is a noradrenergic neuron releasing noradrenaline. So noradrenaline will naturally act on its postsynaptic receptors, which can be alpha 1, alpha 2, and even the beta receptor. And you know the effects already. But what's unique here is that this presynaptic neuron utilizes the alpha 2 receptor, which is on the upper left of the presynaptic neuron illustrated here. The alpha 2 receptor is utilized by the presynaptic neuron as a sensor. So, ang nangyari dyan, when noradrenaline is already released, some of it binds to the alpha 2 receptor. And this presynaptic neuron interprets this as, I have already released my noradrenaline, and therefore I must stop from releasing noradrenaline because I have already released it. So that mechanism is via the action of alpha 2, which is G-protein I coupled. So whenever G-protein I is activated, adenylyl cyclase decreases in activity, CAMP decreases in level, and therefore the stimulation of the presynaptic neuron is inhibited. The potassium channels are activated, and whenever the potassium channels are open, there will be repolarization and prevention of firing of that presynaptic neuron. So at the end of the day, by agonizing or stimulating the alpha 2 receptor, you prevent noradrenaline from being released, and therefore that depresses the sympathetic tone. Special about alpha 2 agonists, methyl dopa is safe for pregnancy, so it's one of the anti-hypertensive agents that we use whenever pregnant women get hypertension. That is pre-eclampsia, yan yung condition nila. And methyl dopa, aside from acting on the alpha 2 receptor, has an additional mechanism of mimicking a neurotransmitter. So remember that in the synthesis of these catecholamines, epinephrine is first synthesized from dopamine. Okay, so um, dopa is the precursor for dopamine, and therefore, when you mimic dopa by giving methyl dopa instead of forming methyl, instead of forming dopamine and epinephrine, you form methyl dopamine, which is not converted to epinephrine and norepinephrine. And therefore, you decrease the active levels of epinephrine and norepinephrine by providing a false neurotransmitter. So, since these drugs act on the central nervous system, and since epinephrine, as it acts on the central nervous system, is a stimulant, by blocking the effects of epinephrine in the central nervous system, we produce depression, CNS depression, which will be commonly manifested as drowsiness. Okay? So, so we've already discussed blockers of the alpha receptors, alpha 1 blockers, preventing vasoconstriction, and alpha 2 agonists or stimulants, which prevent norepinephrine release. This time we'll be transitioning to the beta receptors and their blockers. So first, let us review that there are different locations of beta receptors. So what I want you to understand is that there is usually a mixture of beta receptor isoforms in a particular tissue, but the number of these beta receptor isoforms differ in proportion, such that in the heart there is a predominance of beta 1 receptors, and in the bronchi, the uterus, and the vascular smooth muscle, there is a predominance of beta 2 receptors. And in fat tissue, which is coupled to hormone sensitive lipase, is the presence of beta 3, which causes lipolysis. So those are the beta receptors and their isoforms in their natural habitat. Okay, so first, I want you to understand that our focus here for hypertension would be the beta 1 receptor, such that when we block that beta 1 receptor in the heart, there is a consequent effect of decreased myocardial contractility. So the action of the heart muscle in its contraction, no, decreases, and this translates as a decrease in stroke volume and therefore a decrease in cardiac output and blood pressure. Moreover, beta 1 receptors are also found in the sinoatrial node, which is the pacemaker of the heart. So when we block the beta 1 receptor there, um, the activity of the pacemaker, yung frequency ng kanyang pag-fire decreases, and this leads to negative chronotropy, babagal yung tibok ng puso. So when heart rate decreases, the cardiac output decreases, and the blood pressure decreases. Okay? So what's special is that there is a crossover in the regulation of the autonomic nervous system of blood pressure and that of the humoral control of blood pressure, which is observed by RAAS. So mayroong pag-uusap yung RAAS at yung sympathetic nervous system. So when beta 1 is activated in the kidneys, it actually increases the release of renin. So that when you block beta 1 by giving a beta blocker, you also slow down the release of renin in the kidneys. Okay? So that is an indirect effect of beta blockers. So I want you now to appreciate that there are different subcategories of beta blockers. So we can have non-selective beta blockers, which means that they will block both beta 1 and beta 2. So we would like to avoid these non-selective beta blockers in patients with asthma. Why? Because in asthma, there is pathologic constriction of the airways, and the means by which these airways dilate, bronchodilate, is by way of beta 2. So when you block that by use of non-selective beta blockers, you are predisposing these patients to constriction of the airways. So that will worsen asthma. Okay? So, those are non-selective. Ibig sabihin, hindi niya pipiliin kung ano yung binablock niya, beta 1 ba o beta 2. We also have the cardioselective beta blockers, which preferentially block beta 1. And we have special types of beta blockers with alpha blocking activity, which means that aside from blocking beta 1, they will also block alpha 1. And therefore, their effect, blocking beta 1, decreasing blood pressure by means of cardiac output, will be that will be potentiated by a blockade of alpha 1. So there will be vasodilation together with a decrease in cardiac output, which will be a more potent way of decreasing blood pressure. So you will see that at the second level would be the presence or absence of intrinsic sympathomimetic activity. So intrinsic sympathomimetic activity, ISA, means that these drugs are partial agonists. So instead of being antagonists, they are partial agonists. They bind to the adrenoceptor, but they produce less than the maximal effect of the natural ligand, which is epinephrine. So, napipicture out nyo ba na sa receptor na iyan, they will occupy that receptor and therefore prevent the full effect of epinephrine. But at the same time, if they have ISA, intrinsic sympathomimetic activity, they will provide a little bit of sympathetic activity. So para din siyang epinephrine but minimal effect. So why do we want this? Because we want to block the full effect of epinephrine in its vasoconstriction and positive ionotropy and chronotropy, and therefore treat the hypertension. But we want to preserve a little bit of that function. Why? Because epinephrine is essential for a lot of processes, including metabolism, including stimulation of the central nervous system. Okay, so we don't want a full blockade in these instances. So for example, if your patient is diabetic, and since this patient is diabetic, prone din siyang magkaroon ng dyslipidemia, so abnormal levels of fat in the blood. And one way by which the body processes that fat is by breaking it down, no? Catabolizing the lipids in blood. And the catabolism of lipids in the blood is facilitated by epinephrine. So if you provide a beta blocker without intrinsic sympathomimetic activity, then these diabetic patients who would have otherwise benefited from the beta blocker will be prone to developing dyslipidemia. So we circumvent that by providing beta blockade with ISA. No? intrinsic sympathomimetic activity. So let's just go through, no? Sino lang yung selective? Atenolol, esmolol, metoprolol, bisoprolol, bitoxolol, pevantolol, acebutolol, practolol, celiprolol. Sino yung non-selective? Nadolol, propranolol, timolol, sotalol, tertalol, pindolol, carteolol, penbutol, alprenolol, oxeprenolol. Sino yung with alpha blocking activity together with beta blocking activity? Labetalol, bucindolol, and carvedilol. Okay? So, what's special here? Esmolol. So, esmolol is the beta blocker with the shortest half-life. And therefore, it also has the most rapid effect. And it also has the, it can also be quickly removed from the system, yung effect niya. Kaya ginagamit siya intraoperatively in the form of an intravenous infusion. So when the anesthesiologist would like to control heart rate, bibigyan niyan agad. Pag hindi na kailangan, pwede niya lang tanggalin. No? And the hemodynamics is changed rapidly. Okay. Sotalol is also special because aside from it being a beta blocker, it is also a class 3 anti-arrhythmic. Ibig sabihin nun, meron siyang effect on the potassium channel. Okay? Sino pa yung special dito? Wala na masyado. Most of the beta blockers are also used as pre-anesthetic agents because they will help numb the pain, no? Dahil sa kanilang membrane stabilizing activity. Okay. So, sinabi ko na kanina, there is caution of using beta blockers in patients with diabetes. Why? Because diabetic patients, once they are on hypoglycemic therapy, yung nagpapababa ng blood sugar lower than the normal limit of blood sugar, usually, whenever hypoglycemia is reached, there is a protective mechanism that utilizes the sympathetic nervous system. Why? Because epinephrine will facilitate glycogenolysis and gluconeogenesis so that whenever there is hypoglycemia, which is fatal, by the way, the effect of epinephrine in increasing the blood sugar will protect the patient from fatal hypoglycemia. But whenever we block epinephrine in its activity by giving beta blockers, then that protective mechanism is lost. So, moreover, the symptoms of hypoglycemia, such as sweating, such as headache, confusion, those are glycopenic symptoms, no, cerebral glycopenic symptoms. There is also a class of symptoms, the autonomic symptoms of hypoglycemia. Those are given off by epinephrine. And so once you block the action of epinephrine by providing a beta blocker, these patients will not know that they are in hypoglycemia. So that's deadly. They cannot correct that by taking their crackers or their juices. So this is difficult because they can go into coma and death, no? Because of this hypoglycemia. Beta blockers will also blunt the release of insulin. So caution also in patients with diabetes who have intrinsically decreased insulin secretion and insulin activity. So, binlock mo pa by giving a beta blocker, double jeopardy ka na. And lastly, I've explained this already, beta blockers will block lipolysis. And so patients who are given beta blockers have an increased incidence of dyslipidemia as well as steatosis. So yung taba nagde-deposit sa liver. Okay? Dahil hindi nga na degrade yung lipids. The next type of agents would be the next types of agents, class of agents will be calcium channel blockers. So I've already told you that calcium is important for muscular contraction. And remember that the heart is a muscle. Next, the calcium channel plays an important role in the activity of the natural pacemaker of the heart. So by affecting calcium channels, we are also indirectly affecting the rhythm of the heart. And lastly, calcium channels are also important in the blood vessel where they cause contraction of the smooth muscle. So by affecting the levels of calcium channel inside the smooth muscle of the blood vessel, we cause them to relax. Okay? So calcium channel blockers, are chemically classified as dihydropyridine and non-dihydropyridine. So I want you now to recall the structure of a pyridine. Okay? So you have two chemical classes, non-DHPs and DHPs. So the two principal non-dihydropyridine calcium channel blockers are diltiazem and verapamil. So what's special about these two agents are that they have pronounced cardiac effects. So they decrease blood pressure by altering cardiac contractility, decreasing the stroke volume and cardiac output, and also chronotropy, decreasing the heart rate, the cardiac output, and therefore the blood pressure. So you can recall from your previous lessons that these non-DHP, non-dihydropyridine calcium channel blockers can also act as antiarrhythmics. More so, they are classified as class 4 antiarrhythmics, inhibitors of the calcium channel. Okay, special information about these non-DHP calcium channels is that they have differing magnitudes on their effect on the blood vessel. Verapamil will have equal effect on the heart muscle and the blood vessel. It will cause the heart muscle to decrease its activity and rate in contraction, as well as cause minimal vasodilation, whereas diltiazem will cause pronounced cardiac effects and very minimal blood vessel effects. Dihydropyridine calcium channel blockers usually end in dipine. So amlodipine, okay, nimodipine. So those are just a few of the examples. They have selective effects on the blood vessel. So when they block the entry of calcium into the smooth muscle cell, this smooth muscle cell will start to relax, and therefore the caliber of the arteriole will increase and the peripheral resistance will decrease. Aside from preventing the influx of calcium from the interstitium into the smooth muscle cell, the calcium channel blockers, the dihydropyridine calcium channel blockers also prevent the release of calcium from the sarcoplasmic reticulum, which is a specialized type of organelle in muscles. And the function of these organelles are to store calcium. So by preventing the release of stored calcium, they prevent also the contraction of the smooth muscle. Because there is vasodilation of the vasculature, the capillary hydrostatic pressure increases. And this leads to an increase in net filtration pressure. So, tumatambay or tumataas yung amount of plasma that exudes into the interstitium, and this will lead to peripheral edema. Kaya most of the complaints of our patients who are given calcium channel blockers is that at the end of the day, um, 4 p.m. or 5 p.m. after prolonged standing, they will notice that there is an increased occurrence of bipedal edema or pamamanas. Okay. But other than that, calcium channel blockers are considered one of the safest antihypertensive agents. And in Black patients, so African American patients and patients of color, calcium channel blockers are usually the initial antihypertensive agents of choice. Okay, let's proceed to the last drug class for the treatment of hypertension. And this time, um, let us recall that there are four mechanisms of hypertension, and one of that is an increase in um, blood volume or plasma volume. So by now, I hope you appreciate that the different classes of antihypertensives target one or two of the mechanisms of hypertension. And to address uh, one mechanism, which is an excess in blood volume or plasma volume, we have the last drug class that we'll be discussing, the diuretics. So when you use the term diuresis, you are actually referring to two separate processes, which is natriuresis or the elimination of sodium via the urine, and aquauresis, the elimination of water via the urine. So those two combined is what you call diuresis. So we have a class of diuretics which are not actually natriuretics but only aquauretics, and these are our osmotic diuretics. So let's try to understand how diuretics work, and for us to do that, we should be familiar with the structure of the nephron. So the nephron is actually the functional unit of the kidney, and it is the one that um, filters plasma and continuously modifies the filtrate until it becomes urine. So the time that we call it urine is actually at number 6 of this figure. Before that, we only call it as filtrate. Okay, so the nephron is actually a communication of the blood vessel, which is the pink curly structure that you will see here, and the specialized epithelium of the kidney. Okay, so these epithelia contain specialized cells that continuously modify the filtrate that comes from the blood vessel, modifying it by changing the amount of solutes and the quality or type of solutes in it. Okay, so um, if you will know that in number 1, you will see the glomerulus, and you will notice the tuft of capillaries that communicate with the Bowman's capsule, which is the light orange coloration, letter C, enclosing the glomerulus. Okay. Number 2 is the proximal convoluted tubule, and the adjective convoluted means it is curled up. Then you have number 3, the loop of Henle, and particularly that is the thick ascending loop of Henle. Number 4 is the distal convoluted tubule. Number 5 is the connecting tubule, and 6 is the collecting duct. Okay? So, what are the processes that occur in the formation of urine? Number 1 is glomerular filtration. the plasma that is present in the glomerulus is pushed out, much like in our discussion of the Starling's forces, into the Bowman's capsule. And as it is pushed out, it traverses through a highly selective membrane, which is the glomerular basement membrane. So the first process is glomerular filtration. The second process is passive tubular reabsorption. And the third process is active tubular secretion. Okay, so those three processes occur continuously, no? Um, Providing the filtrate via glomerular filtration and then modifying the filtrate via tubular reabsorption and active tubular secretion. Okay, so in number two, the proximal convoluted tubule, what happens is the reabsorption of majority of sodium, water, and other constituents of urine, such as amino acids and sugar. Okay, what happens in number four, the distal tubule, is the reabsorption of much of the sodium and chloride and much of the calcium. What happens in number four would be the reabsorption. Number three, sorry, what happens in number three would be the reabsorption of sodium, potassium, and chloride in the form of a co-transport. And number six would be the selective reabsorption of water via aquaporin 2. Okay. In the connecting tubule is the process of selective sodium reabsorption. And that is facilitated by the epithelial sodium channel. Okay. So let's recap. Filtration at number one, reabsorption of majority of sodium and water and other constituents at number two, reabsorption of sodium, potassium, and chloride at number three, reabsorption of sodium, chloride, calcium, and magnesium at number four, reabsorption of sodium at number five, and reabsorption of water at number six. So let's first discuss the first type of diuretics, the thiazide diuretics. Thiazide diuretics are effective and they are often used as primary or initial therapy in the treatment of hypertension. And thiazide diuretics are especially helpful in patients who have sodium sensitive hypertension or salt sensitive hypertension. Ibig sabihin nun, yung kanilang hypertension is primarily due to an expansion of the blood volume because of excess sodium in the blood. So once we remove the sodium, we treat the hypertension in these cases. So thiazide diuretics will block sodium chloride co-transport in the distal convoluted tubule. So by blocking sodium and chloride reabsorption, the levels of sodium in the blood decreases, the blood volume decreases because where sodium is, water follows, and therefore the preload decreases and the cardiac output decreases. Blood pressure decreases. So an adverse effect of thiazide diuretics would be hyperglycemia and hyperuricemia. Okay, and we have to be familiar with the thiazide diuretic braking effect. So this phenomenon is observed because of compensation of the nephron. So remember that the effects of thiazides would be to reabsorb sodium, to prevent the reabsorption of sodium. And as you will see, adjacent to the distal convoluted tubule would be the glomerulus. So what happens in the thiazide diuretic braking effect is because the thiazides are preventing the reabsorption of sodium, the glomerulus reacts by increasing glomerular filtration. So what happens is there is vaso uh, dilatory substance release to provide vasodilation of the glomerulus and increase the glomerular filtration, so that even if sodium is prevented from its reabsorption, the delivery of sodium to the distal convoluted tubule is maintained. Okay? So that is the renal compensation there. This is very much a welcome phenomenon in the treatment of hypertension, because we see that in patients who are given with chronic regimen of thiazide diuretics, we see that um, much of the sodium is actually um, reabsorbed again, but on top of that, what provides the antihypertensive effect is the vasodilation. That is the consequence of the thiazide diuretic braking effect. So, hindi lang sa blood volume yung epekto niya, but also in the control of peripheral resistance. Okay? So the side effect of this is hypercalcemia, and we want to utilize this side effect in patients who are osteopenic and those who are at the brink of developing osteoporosis. Okay, so we want to conserve calcium in the blood. Okay, next would be loop diuretics. Loop diuretics act on number 3, where there is the powerful reabsorption of much of the sodium, potassium, and chloride. Okay, so a process that is occurring in the loop of Henle is the countercurrent regulatory mechanism, and that is quite an advanced concept of physiology. So what I want you to understand is that surrounding the loop of Henle is a collection of sodium. And so if you prevent the reabsorption of sodium here, okay, that surrounding tissue will lose its store of sodium. And therefore, you won't be able to concentrate the urine. If you will not be able to concentrate the urine, you will lose a lot of water. And so this provides the powerful diuretic effect of loop diuretics. The loop diuretics are so powerful that in just a span of hours, you can lose up to kilograms of body weight um, in terms of water. So loop diuretics, because of that, are utilized in the treatment of fluid overload. So whenever there is severe edema from lots of causes, especially in heart failure. So we want to decongest usually the lungs of these patients being filled with water by utilizing powerful diuretics. And in this case, that's the loop diuretic. So this is a non-sealing diuretic. Ibig sabihin ng phrase na non-sealing, if you increase the dose, you will progressively see an increase in effect. So walang limit, no? Parang morphine. If you continuously increase the dose of morphine, you will see a continued increase in analgesia. Okay, so dito din sa loop diuretics, pa-increase ka ng pa-increase ng dose, you will see an increase in diuresis. Okay? But what limits that would be the occurrence of adverse effects, which are more common in loop diuretics. Bakit nga? Kasi sobrang powerful niya na diuretic. And therefore, its effect on electrolyte imbalances would be very potent also. You will see hypokalemia, hyponatremia, hypomagnesemia, hypocalcemia, and even, in some cases, hypochloremia. Okay? Lastly, let's discuss the potassium-sparing diuretics. So the potassium-sparing diuretics block the effect of either aldosterone or the epithelial sodium channel, ENaC. Okay? So remember that aldosterone is a mineralocorticoid and it acts as a transcription factor in these regions of the nephron. So the effect of aldosterone as a transcription factor would be to increase the levels of the sodium potassium ATPase pump and the levels of epithelial sodium channel. So once you block the activity of aldosterone by um, giving these kinds of diuretics, then the levels of ENaC will decrease and therefore your reabsorption of sodium will decrease. Okay, so examples of those kinds of diuretics which block aldosterone would be spironolactone, okay, and another way of blocking the effects of um, so the effects of aldosterone would be to block the sodium channel directly, and these are your epithelial sodium channel blockers, which are exemplified by amiloride and triamterene. So remember that to reabsorb sodium from the urine, the levels of sodium inside the cell should be low. And so there should be a mechanism that will continuously provide low levels of sodium inside the cell. And this is via the activity of the sodium potassium ATPase pump. So that function is provided by the action of aldosterone. So by blocking aldosterone, you block sodium reabsorption. But you also block the excretion of potassium. That is why these agents are called potassium-sparing diuretics, because you block sodium reabsorption, therefore decrease the blood pressure, but at the same time, you prevent the potassium from being eliminated. Okay? So, what is a usual um, use of these mechanisms? Remember that the thiazides and the loop diuretics, they can cause hypokalemia. So, another way of utilizing synergy would be to prescribe loop diuretics, moderate to low dose, together with a potassium-sparing diuretic so that you prevent hypokalemia from developing. But at the same time, you potentiate the blockade of sodium reabsorption. Okay? And lastly, there is a hormone that is produced by the brain that is stored in the posterior pituitary gland, and that is antidiuretic hormone or vasopressin, which acts to increase the levels of aquaporine in the collecting duct. So this is what mediates water reabsorption. So once you block that, you also prevent water reabsorption. So um, this is utilized in patients which have um, peripheral diabetes insipidus. Okay, so we want to block the activity of vasopressin in the kidneys, and we utilize agents such as the tetracycline derivative demeclocycline. Okay, so yun yung example ng ating vasopressin antagonist. Okay, so we've discussed a lot, and this is the summary. Okay, we have a lot of mechanisms of controlling blood pressure. Acute control of blood pressure provided by the nervous system, and therefore we can block that using beta blockers and alpha agonists. Or we can block the long-term control of blood pressure, which utilizes activities of the kidney, RAAS blockers, and diuretics. And we can also block an increase in blood pressure by causing vasodilatation um, of the arterioles. And primarily that is mediated singly by the dihydropyridine calcium channel blockers. Okay, so just take a quick minute to take a look. You have here the location of central acting adrenergic antagonists, alpha 2 blockers, and some beta blockers. You have peripheral acting adrenergic antagonists, alpha 1 blockers, and beta blockers. Okay. You have calcium channel blockers, the direct acting arterial vasodilators such as hydralazine and minoxidil, which I chose not to discuss. Alpha and beta adrenergic blockers, ACE inhibitors and inhibitors of the RAAS, ARBs, okay, and renin inhibitors and diuretics. Okay, so I hope you learned a lot. Just rewatch the video and read your textbook because your textbook is your best teacher, second to experience. Okay, thank you for listening.